Great. So today is Thursday, April 10th, 2025, and want to welcome all of you attending in person or virtually at some point in the future. Want to welcome you to the latest installment of our Advancements and Breakthroughs in Andrology Conference. We're really pleased here at Northwestern Medicine to provide these sessions for you, which we think help to provide information that may help you in your care of patients as you're going through your day-to-day practice. And today we're so excited to have Kristin Smith with us. Kristin Smith is the program manager for fertility preservation here at Northwestern Medicine, but her footprint extends well beyond Northwestern Medicine. Really, she is a pivotal figure here, not only in the United States, but also globally, with helping providers and patients to receive and deliver the fertility preservation care that they need. She's incredibly available and is a resourceful person who's also a problem solver and friendly and encouraging along the way, which is just what our patients seeking fertility preservation need. So Kristin's a dear friend, and her presentation today is Navigating Patients for Fertility Preservation, and very excited to have you speak to us today, Kristin. So with that, welcome. Let you get going here.
I mean, might be the warmest welcome I've ever gotten. Best introduction. Thank you so much. I will try to live up to that. And just really thrilled and honored to be here kind of sharing patient navigation for fertility preservation. I'll talk a lot about what that looks like at Northwestern, and then I also have some across the country navigation experience to share as well. And, I think when we think about patient navigators, this was really sort of a big buzzword in the early 2000s in oncology care, and kind of started in New York in a breast center where essentially one of the physicians felt like his patients weren't getting the thorough care that they needed and weren't getting followed up with. So he developed this patient navigation model. And essentially what it means is to get a patient from A to B to C as seamlessly as possible. And for me in particular, as a patient navigator for oncofertility, it's really about ensuring that patients have access to the information they need to make the best decisions for themselves now and in the future. And in particular, talking about fertility preservation, we're going to really be focusing today on adolescent and young adult oncology. And the NCI designates that as ages 15 to 39. It's estimated that there are just over 84,000 new cancers in this age range in the United States. And survivorship is getting better and better and better. And that's been really amazing to watch in my now 15 years here at Northwestern. 5-year survival rates are up almost at 86%. And I think not surprising for any of you who take care of these particular patients, the most common types of cancers among these AYAs, particularly for males, are thyroid, testis, melanoma cancers. And then the most common cancer types of that cause death amongst these patients for female patients, mostly breast, and then brain and colorectal cancer, leukemias. We are seeing some of these incidences increase over the years, and in particular for AYAs, we are seeing an increase in melanomas, colorectal cancers, and some lymphomas as well. And then when you break these new cases down by type and sex, you can see, again, not surprising, the vast majority of our young adult male patients are presenting to us with testicular cancer, but then a good percentage also with colorectal, lymphomas, leukemias, and brain tumors as well. And we know that AYAs in oncology have very different disease profiles than their pediatric or older adult counterparts. The genetic profiles look very different within their diseases. These patients respond differently to particular treatments and protocols. And if you think about where you were in those ages of 15 to 39, you had a lot of very specific life and social needs. And these patients are the same, whether they're in high school or college or, in their new job or newly married, building their families. There's a lot that's happening in these decades of life. And Archie Blyer, who was really one of the pioneers of recognizing the importance of AYA oncology, really developed sort of these key pieces that are necessary to have a comprehensive program at a cancer center. And that comprehensive program involves getting patients involved in clinical trials. We know that AYAs are less likely to be enrolled in a clinical trial compared to pediatric or their older counterparts. These patients need specific psychosocial support. Again, they've got lots of things happening in their lives, and having that psychosocial support is so important. We also know that health insurance in the United States can be really complicated. And so for a lot of these patients, they're, either getting kicked off of their parents' health insurance because they're newly 26, or, they have their first job and they just got health insurance, or in a lot of cases, they are either uninsured or underinsured. And so having access to financial counselors is a huge plus and need for these AYA patients. And I think no surprise that we're going to be really focusing on number 2 here, the fertility counseling. It's particularly important that we're addressing patients' biological desires, wants, and needs to become parents in the future, and giving them options if those exist for those patients. And we have guidelines galore to support us in that, right? So pretty much any medical society who would have some type of interaction with an adolescent or young adult cancer patient now has a guideline that says you should be offering sperm, egg, and embryo freezing for these patients. These are standard procedures. Patients should have a consult, and they should have options offered to them. And so the way that we do that at Northwestern is with this patient navigator model. And as the patient navigator, I kind of like to think of myself as the middle woman. So I am that middle person that when a patient is seen in oncology, they know that they can send those patients right to me, and I can have initial conversations with them. And while, yes, we're focused very much so on oncology today, I think it's super important to note that we're seeing patients from a variety of specialties within the hospital. So any patient who's receiving cytotoxic chemotherapy, some of our patients from rheumatology, neurology are getting Cytoxan, for example. We also see quite a few patients from the gender clinic prior to them starting their gender-affirming hormone, so that we can offer fertility preservation as well. But the vast majority of patients we are seeing do come from our oncology colleagues. So the goal for that is that we have this initial referral to me as the navigator. I get patients either right into urology or right over to reproductive endocrinology as quickly and seamlessly as possible, with the goal being that patients can either just have that consult and move on, or complete fertility preservation, but get right back to their treatment team, so that we have as minimal delay to starting treatment as feasible and possible. And I think it's important too, as sort of the involved in all these extra groups as well. So I also work really closely with our basic science and research teams. And when we had the Oncofertility Consortium here at Northwestern, we had a really big, sort of very robust lab doing ovarian tissue freezing research. But now there are labs really all over the country, and we can really help collaborate and provide new ideas and insights, so that we can take some of these fertility preservation methodologies from the bench to the bedside much, much faster than we usually would. And I think, there's always that question, I think mostly from administration within hospitals, like, does actually having a standardized program or having a patient navigator, does that make a difference in whether or not patients are offered fertility preservation? And I think I'm preaching to the choir here. No duh, right? Obviously it's going to help, but sometimes they need to see that proof. So thank you to Jason Hedges and Dr. Brannigan, who very early on in 2012 published on this, essentially showing that when you have a standardized program, and in 2006, that's when the Oncofertility Consortium was started here at Northwestern, basically sperm cancer patients who were seeking consults and then actually banking sperm doubled. And that was looking at over 5,000 male patients aged 18 to 55 from 2002 to 2010. And then Mass General did something very similar, where they looked at 7,000 female patients, and they showed once they instituted a standardized program, the consults to reproductive endocrinology nearly doubled in that program. And then, something that was a bit of a newer project actually came out of Johns Hopkins. And this was really oncology fellow led and driven. They created a quality improvement project where they noted that, less than 40% of patients were having a consult related to fertility preservation. And they instituted an interdisciplinary team so that They could both teach all the other providers about the importance of oncofertility and counseling. They instituted kind of a navigator-like model where the oncology fellows sort of served as that navigator. And what they showed was that in an 18-month time, counseling improved from 37% all the way up to 70%. So, I think for any administrators who are questioning whether or not they should be paying for a navigator, paying to help support these programs, I think it makes a huge difference in our clinic's ability to care for patients. And there's a really robust oncofertility patient navigator group now through the Oncofertility Consortium. There's about 90 of us who kind of serve as this patient navigator role really around the world. And what we did about a couple years ago was to send out a 31-question survey to our group. And we got a 43% response rate from 14 states in Canada. You can see all the blue dots are where we got responses from. And basically, we just wanted to know more about patient navigators and more about each individual person, what their role is. So I'm going to share some of those survey results with you. And so one of our first questions was kind of, who are you and who pays for you? Because I think that's a big question that I get pretty frequently. So the vast majority, more than 50% of the group, are either APPs or nurses, and more than about 65% of that group is paid for through oncology, actually. There are only 4 of us in the survey respondents who are paid for by reproductive endocrinology. That's how I get paid, is through that clinic. And actually 0 were paid for by urology, which I found to be really interesting. We also asked, how many years of oncofertility experience do you have? And I think what's unique about this group is, oncofertility is a relatively new-ish kind of field. The term was coined in 2006, so we're, just looking at roughly 20 years here. And there's about a third of us who have been doing this sort of 5 years or longer, but another third who are really brand new to this role have been in it for 0 to 2 years. And I think what's beautiful about having this mix of years of experience within this navigator group is that you get these new navigators coming in with new ideas, new ways to track patients, new access to technologies. And then you have these years of experience where when you have a difficult case, it's most likely that someone in our navigator group has dealt with that type of difficult case as well because of these years of experience. So it's a really great group. We meet kind of once a month. We then also asked, how much time do you get in oncofertility? I'm 100% oncofertility. This is my whole world. But the vast majority of the navigators actually don't have all of their time dedicated to oncofertility. And most of them have other duties that they need to do. So, for example, if oncology is paying for them, it could be that they are an oncology staff nurse for 50% of their time, and then they have 50% of their time dedicated to oncofertility. We then asked, at what point do you see these patients that are coming into your clinics? No surprise that all of us are seeing patients at diagnosis, but also the vast majority of navigators are happy to see patients during active treatment or during surveillance or into survivorship as well. And I think if you ask most navigators, they will see a patient anytime, anywhere, anyhow. If a patient needs to be seen, they're happy to be there to provide that care. We also asked about responsibilities and specifically, what are you tasked with in this role as a navigator? I think it wasn't surprising to any of us that, most navigators are giving informal counseling to patients on risk of infertility, fertility preservation options. Also, as the job title would suggest, they're actually navigating patients to specific referrals, making sure that providers have what they need to see these patients. What I was personally pretty surprised about, though, was that almost 80% of our navigators are also tasked with educating all the staff in their areas and growing the program as well. And that can be really tough to do if you don't have enough time to be able to do all of those activities and you don't have that background. We also asked a little bit about salary. And I think this lines right up with the majority of our navigators being APPs or RNs. A good chunk are making $100K or more per year. I then, kind of did a little bit of a deeper dive into data, and kind of, one question that we asked was about how many new AYA cancer patients are coming through your door per year, and then how many fertility preservation consults are you doing per year? And I think, it's not surprising, but it was good to see it play out in the data, was that when you had a navigator who only was able to do oncofertility, less than 25% of the time, they were only capturing about 25% of new patients coming through the door. And if you have a navigator who can devote more time to ensuring that they have, are able to see these patients and provide consults, then you're capturing patients about 75% of the time. So not surprising, but I think it's nice to see that, when a navigator has 50% or more of their time dedicated to oncofertility, they're going to be able to see more patients. And that's really what this is all about. We also asked our patient navigators about barriers to oncofertility care. And, one thing that they all said is that they need more partners, and specifically they need more reproductive endocrinology and urology partners. They did not feel like they had enough people that they could reach out to give patients options for banking locations, or having staff within those clinics who can help provide additional care and support. They also felt like cost was a big barrier for a lot of our patients. And I think this probably speaks a little bit more to like the egg and embryo freezing side of things, where we know that cost can be in the thousands of dollars versus the typical hundreds of dollars for sperm banking. But also having clinics require upfront payments or requiring cash only, and they won't bill insurance. That can be a really big barrier for a lot of our young adult oncology patients. Timing was a huge issue, getting these new referrals, getting them quickly, and then having that protected time so that they could actually go see the patient and give a proper consult. And then they also felt like there was, some insight lacking from the provider side of things, unfamiliarity with the actual risk of treatments to someone's fertility, and some, preconceived notions about someone's status, maybe someone assuming they can't pay for long-term storage, so they don't even offer banking or things like that. We did publish as this navigator group in Pediatric Blood and Cancer a couple of years ago, specifically on oncofertility patient navigation. And so, if you want to kind of read more about these barriers and kind of what a navigator does, that's a really great article, a good summary for all of us. And, I'm going to talk a lot now about Northwestern and what we do here at Northwestern. And you're probably going to hear me say it too many times, but I feel very lucky to be at Northwestern. And one of the big reasons for that is because of our insurance coverage. So, the state of Illinois is a mandated fertility state. So across the board, we have really pretty good coverage for fertility preservation and fertility preservation services. And then subsequently have generally really pretty good coverage for the necessary assisted reproductive technologies that patients are going to need to build their families with what they have frozen. So I think we're lucky here, but I certainly know and understand that's not the case everywhere around the country. So I will say, the team here at Northwestern, when a patient comes through the door, and this is really more about, the egg banking, embryo banking side of things, where we've got multiple CPT codes we're verifying. But we, when we're talking to insurances, we're talking about fertility preservation benefits. We are not talking about infertility benefits. And I think that makes a big difference in how you are talking to insurance, and then also how you're coding all of your procedures. So when we're sending in, lab tests and things like that, we're not sending it in under N97.9 infertility, because we're not seeing those patients because they're infertile. We're seeing them because they have cancer and they may become infertile and need to do fertility preservation. The picture that you see here is then Governor Bruce Rauner of Illinois was at Northwestern to sign our House Bill 2617 into law in 2018, which made fertility preservation a mandate for us here in Illinois, and has been, I think, really instrumental in allowing our patients to choose fertility preservation based on medical necessity and not based upon their bank account. And for anyone else around the country, I also want to include this map from the Alliance for Fertility Preservation, because what it really shows in green are all the other states that have some type of fertility preservation coverage through legislation. What you see in the blue states are where legislation has been introduced. The yellowy states, something was introduced but is now inactive. And then the white states, kind of nothing has been introduced yet. So our goal right here is that the whole map is going to be green at some point. Our ideal goal is that we're going to have some type of federal coverage at some point, but as you can all guess, that's going to take a while. So we're kind of working in this state to state. If you're listening to this, watching this later, and you happen to be in one of these states where there's new legislation or legislation that's no longer active or no coverage at all, and you want to get involved, the Alliance for Fertility Preservation is a really great place to get started. You can certainly contact me as well, and I can help with that too. So we need as much help as we can get as we get these laws passed across the country. So when I am first meeting with a patient and getting, the diagnosis and the treatment plan, as I'm thinking about that treatment plan, I'm kind of bucketing those treatments into low, moderate, and high gonatotoxicity. I think there's a lot that we still need to learn about some of our biologics, like our tyrosine kinase inhibitors, immunotherapy, some of those more targeted therapies that are listed kind of here in this moderate toxicity, but honestly, we don't know because the FDA doesn't test necessarily fertility on a lot of these drugs. So I think we have a lot to learn about those still, but there is quite a bit that we do know about some of these, older therapies, the alkylating chemotherapies, pelvic radiation, any type of stem cell transplant. We know that those patients are all going to be at a high risk for infertility after their treatment. And Dan Green, who's down at St. Jude, I think really, back in 2014, published one of the first pretty comprehensive studies doing a semen analysis on adult survivors of a childhood cancer. And not only was he doing that, but he and his team were also able to create what's called cyclophosphamide equivalency dosing. And this is where they sort of assigned weighted numbers to all the different alkylators that exist and that we typically use to treat our patients, and created a calculator so that we could really all be using the same language when we're talking about chemotherapy and utilizing the cyclophosphamide equivalency dosing. And what they saw when they looked at adult survivors of a childhood cancer is that, 4 grams per meter squared and less, for most patients, they had, normal sperm counts and concentrations afterward. But as you started to get above that 4 grams per meter squared, we started to see sperm concentration in particular decreasing as that got higher and higher. This has really impacted, the way that we assign risk, particularly in the pediatric population. And I'll share a really great table on that in a couple slides. I think it's a no-brainer that radiation is going to have a bad and negative impact to spermatogenesis. I think sometimes what everyone doesn't always think about, though, is high-dose cranial radiation and the impact that that can have on the pituitary gland and its ability to make follicle-stimulating hormone, which, as you all know, kind of kicks off all that stuff. So I find with a lot of oncology providers in particular, I have to really ensure that they're thinking about fertility across a variety of treatment modalities and not just some of the more kind of common ones that they know. It's just a nice little table of all the high-risk chemotherapies in particular. Alkylating agents we know are going to be pretty damaging to the spermatogonia cells. Some of the heavy metals, particularly for males as well, are going to have a very negative impact on those spermatogonia cells. And then we have these non-classical alkylating agents. Dacarbazine is one we typically see in lymphoma patients. Temolazide, one that we see oftentimes in our brain tumor patients. While they kind of act like an alkylating agent, don't seem to have that same long-term infertility risk. But, I think we all could do a lot more to study those particular risks and do a better job of figuring out if we can start to assign higher percentages or, actually give percentages to some of these risks. The Pediatric Initiative Network, or the PAC group now, through the Oncofertility Consortium, did create this beautiful table. And again, it's really more for pediatric patients, but to kind of line out what are the levels of risk associated with particular treatments for our oncology patients. And I think what this has been particularly helpful in is sort of determining, mostly for our prepubertal patients, do they qualify for experimental fertility preservation options? Knowing that we don't want to do an experimental procedure in someone who's going to have, minimally increased risk of infertility post-treatment. But, for our prepubertal patients who we know are going to be in that high level, we should be able to hopefully offer them something like testicular tissue freezing, which is really the only option that's available for our prepubertal patients. For the vast majority of the patients that I see, because I'm in the adult hospital, when I'm meeting with them, talking about their risk, we're talking about sperm banking. That's for sure. The vast majority of our patients are able to bank sperm. A small percentage of them are either unable to produce a sample or azoospermic, and then we, send them off to talk again about oncotesting and what that looks like. And in a very small percentage of adult patients, we have done testicular tissue freezing. It's been very case by case specific. I can think of maybe 3 that we've had in the last 7 or 8 years. And just, in our clinic, what does this look like? And so I pulled a recent patient that we had seen. This patient was seen in our oncology clinic. It's a 24-year-old, recently diagnosed with Hodgkin's lymphoma. This particular patient's been experiencing night sweats, cervical lymph node enlargement. Biopsy showed Hodgkin's lymphoma. They saw the oncologist. The oncologist sent this patient to me via our Epic, and I called the patient, talked through risk of treatment, which was pretty low risk. We did not expect this patient to be azoospermic post-treatment. And then I had them see our most amazing PA, Val Brown. And I think Val should deserve PA of the decade. She has been such an amazing resource for us. And honestly, between Val and Bob, I am asking them to constantly add on patients. And even on these days where they're seeing, 45 patients in consult, they're always just so amazing about throwing these patients into their schedule as well to make sure that patients can have, that conversation about fertility and fertility preservation and making sure that they've got this touch point of really amazing reproductive urology care. So huge shout out to both of you, and thank you both for always putting up with all of my add-ons. This particular patient then went right on to sperm banking. And this moved so quickly that literally we were done sperm banking 2 days after this initial oncology consult. And I think that just really speaks to, how we've set up this program. We've got some really well-worn pathways so that patients can get in and out very quickly. And Bob kind of mentioned it at the outset about my availability. And it's true. I will take a referral any way that oncology wants to give me a referral. So for some people, it's a direct Epic message. Some people like to text me. Some people like to call me. Some people like to page me. We do have a best practice advisory that's available within Epic. So, if a provider prefers that sort of best practice methodology, they can choose that. I'm also actually just working with our IT team to include within the REI referral an option to be able to choose an urgent medical fertility preservation referral. So what I've noticed, especially with some of our outside hospitals, is that they'll put in an REI referral that goes to our general infertility pool. There's like 1,500 patients sitting in there right now, and I'm not getting those. So hopefully by adding this like urgent medical fertility preservation button, when an oncologist is doing that, they can select that, and it's going to come right to my medical fertility preservation action pool within Epic. We've really set up our Epic so that we can take care of these patients quickly. I have the capability to do scheduling. So if I talk with Bob or Val and they say, yeah, you can add this patient on here or there, I can actually then go right in and schedule it. I don't have to wait for anyone else. Oftentimes now we're seeing a lot of these patients via telehealth, which is so nice for the patient to not have to make extra trips. But if that patient's going to be on campus for other oncology visits, I will try if I can to get the patient seen in person as well, in conjunction with some of their other, lab scans, office visits, things like that. And then we're going to send that patient all their consent paperwork via MyChart so that we've got a really nice record of having conversations with the patient, sending all the appropriate paperwork, and then putting in those orders for infectious disease labs, hormone labs if necessary, and then the semen freeze as well. Within the fertility and reproductive medicine team, they have specialty appointments for medical fertility preservation patients so that we can get them in for banking. And I will tell you, they're pretty much always taken. And I'm oftentimes also asking them for add-ons, but I have a very particular group of andrologists that I have direct Teams messages with where, we can message in, talk about doing add-ons, figure out what's going to work out best for them so that we are certain to, be able to take care of all of the patients that we need to here at Northwestern. We also have phlebotomy right within the fertility clinic. So if a patient is going to be coming in for sperm banking, they can get their labs drawn right then and there and not have to do an additional appointment as well. We certainly do have patients who coming all the way into the city is cumbersome and that's not something that they want to do. So then we do talk to patients about options for mail-in kits. And typically we're either talking about doing that mail-in kit through Reproductive, who partners with the University of Illinois here in Chicago, their overnight mail kit, or offering the fellow kit. I think what's great about both of these is that patients can go right online. So no matter what time it is, they can go online, they can order these kits. We know that these are great companies. The kits get shipped directly to the patient. Patient can collect and then send those kits right back out. So I do have, quite a few patients who are opting for some of these at-home banking kits. And oftentimes it's my patients who are really, really, really sick or who live out kind of far away in the suburbs and just can't physically get into the city. And these have been really great for a lot of those patients. We also see inpatients, right? So there's always going to be this urgent need to see an inpatient. And I wanted to just kind of share, what that typically looks like. So for this particular patient, it was a 29-year-old, presented to urgent care, hadn't been feeling well, got admitted for an urgent workup, and a bone marrow biopsy showed that he had B-cell ALL. So our leukemia team paged me right away. I then share that page with Bob and Val. And between sort of the three of us, we kind of all figure out, okay, who's going to go see this patient first? And if I can see that patient first, I will, so that I can sort of do just an initial introduction about fertility preservation, bring some of that paperwork so that Bob and Val don't have to do that. It takes quite a while to fill out all that paperwork. And I try to kind of pull up what that treatment plan is. And so for this particular patient, they were going to be enrolled in CALGB 10403, which I then have to Google, right? I can't remember all these different protocols. So I pull up what this patient's going to get. We know that Cytoxin is in this protocol. We know that oftentimes these patients may also end up going to a stem cell transplant. So we definitely talked about and encouraged sperm banking, and this patient indeed did bank sperm. Didn't have great sperm counts, right? But we were still able to get 3 samples from this patient. So we've had 3 vials of sperm, which was great. That sperm got frozen, got sent off to long-term storage. This patient did undergo a stem cell transplant, sadly did relapse 4 years later, started on immunotherapy. This guy's been through a lot, but he and his wife returned to us in April 2022 to start talking about their family building. And we talked to them about IVF with ICSI with these low sperm counts. And they just had a healthy baby boy in October of 2023 and actually just returned to us again to talk about baby number 2 with us. So from that one of those vials of sperm, we were able to give them a healthy baby, and hopefully we'll thaw 1 more vial and give them another child. And I think for them, they said 2 would complete their family building. But I mean, what an amazing thing to be able to have this sperm on hand that we could then go to for them. I think another really important place that we see these patients is in survivorship. And, we're getting referrals either from our STAR team, which is Survivors Taking Action and Responsibility, or the actual treatment team itself. And when I get a referral for these also come through me. I do try to put together a treatment summary with cumulative chemotherapy, radiation therapy doses, any type of surgery. Was there a transplant? I do also try to pull, were we able to do some pre-treatment banking? If so, what did that look like? And then I set them up for an office visit with Val or Bob. Again, they're so lovely at letting me put all these patients on their schedule, where they're going to have a full consult, oftentimes get hormone levels drawn, get a repeat semen analysis, and just kind of, see where things are at. And then they can help counsel patients about next steps. So I wanted to share actually this very recent patient that we had. It was a 30-year-old male. He also had ALL, diagnosed back in 2012, also did that same protocol, that CALGB 10403. At the time, we were immediately consulted. He did bank sperm. We also had 3 vials of sperm saved for him. Underwent a stem cell transplant. And then just earlier this year, his treatment team reached out to me and said, oh, he just got married. He's really excited about building his family. So when I called him, I plan to talk about, likely needing to do IVF with this. Well, when I spoke to him, he let me know that he had discarded his sperm after 8 years of storage. I know. I felt like my heart was going to sink. He felt like he just didn't need to keep paying for storage. He felt like it was expensive. He didn't really talk to anyone about it before he chose to discard it. He just chose to discard it. But he assumed that he had sperm now because he was feeling pretty good. He did see Val in follow-up. She did all the tests, and sadly, and I think not surprising for any of you, he's azoospermic. And so now we're talking about alternative ways to build their family. So, I think in this case, Val and I were both like, oh man, I wish he would have talked to one of us before he discarded what he had in storage, because then we could be talking about biological family building. But just, I think survivorship is another really important piece of this oncology care, to continue to provide support, resources, for these patients who, maybe already bank sperm, but, maybe now are questioning whether or not they should keep that sperm. And I just wanted to include what I call the pathway for partnership. I think as you think about your own program, as you think about, what does an ideal program look like? I think from a urology, reproductive, endocrinology, sort of point of view, you need to have very open scheduling and availability. These patients can come rapid fire. I think I've had Val ask me, am I holding a sign out on the sidewalk? Because we'll have weeks where we have, 10 patients, and then the next week we have no patients. And so it's not always a steady stream of patients, and sometimes it can be a little unpredictable. And to be able to have some of that flexibility with scheduling is crucial for these particular patients. It's nice, and I'm so lucky here that I've got someone like Bob and someone like Val who have all this knowledge on treatment and the impact to fertility and all these amazing years of experience, that not only could I learn from them, but then they can, share all that information both with providers and patients. And you need to be able to take care of really diverse patients. And I think not everyone can always do that. Not everyone can always pivot as quickly as is needed for these particular patients. It can be really helpful within your office to have sort of a fertility preservation champion, if you will, someone who can maybe help get these patients a little sort of one-on-one time. If you have a navigator, it can be that person. But if you don't, maybe a nurse or, someone who can really spend a little extra time with these patients, make sure they have everything that they need. And I think providing funding for roles is really crucial. I do, feel lucky that the REI clinic pays for my funding, but I think in some cases, oncology is not always able to pay for funding. And so it makes sense sometimes for REI and urology to pick up some of that funding as well. And that could be an area where you get some additional partnerships. From the cancer center, there has to be this very seamless referral pathway. It has to be well worn. It has to be well worked out. And again, I think navigators can do a great job at making that, creating that, and then ensuring that it's running smoothly. And I think, for me, it was really crucial that I attended a lot of those care conferences. I attended a lot of tumor boards within the cancer center. They were always really happy to have me attend those, happy to have me ask questions. I shadowed a lot of the oncologists in clinic so that I could get some of that knowledge and kind of hear how they're counseling patients, and they could hear how I'm counseling patients, which I think is important. And I think if you are interested in being a navigator, if you're interested in, having someone in your office, become kind of this navigator, fertility preservation champion, there's a really great program called ECHO. It's completely online, does offer continuing education credits, but really is just all about teaching someone how to have great communication skills for oncofertility and, sexual and reproductive health. ASRM also provides a free course that also provides CME credits. And then the Oncofertility Consortium Conference is coming up this year in October. It's the 17th annual conference. It's going to be in Detroit this year. The theme of the conference is Bridging Cancer Care and Parenthood, Innovation for Healthy Live Births and Oncology. They're also going to be offering an Oncofertility 101 course that Monday morning, and it can be virtual or in person. We'll also offer CME credits, but will really be a great place too to get some basic oncofertility knowledge from sort of all the different perspectives of adult medicine, pediatric medicine. And with that, I will leave you my name, my email. Please feel free to reach out if after this you've got questions or want to chat through anything. Don't hesitate to shoot me an email, and I'm happy to help in any way that I can. Again, thank you so much for allowing me to be a part of this Breakthroughs in Andrology. I appreciate it.
Thank you so much, Kristin, for the, all the wisdom that you shared during that talk. Really helpful. A couple of things I'm hoping you can comment on for our colleagues is, for someone coming up within the field of navigation, you provide a great framework for training, which I didn't even know existed. So it's great to know that there is a formalization of this process. But, for our colleagues who are just coming into the field, I know a lot of them are, emailing you, calling you, curbsiding you at meetings. What advice do you give them within the sphere of fertility preservation as they're getting going with their career? It's such a delicate dance between, fertility preservation and then insinuating this care in the midst of very busy, complex oncologic care. So what words of wisdom do you have for those individuals who are just getting going in their career?
Yeah, I kind of harken back actually to information and advice that my grandmother gave me, where, it's that you catch more flies with honey than vinegar. And I think that speaks to this as well, where, I think it's really important to be kind. And I think you need to start with a place of kindness and sort of understand that, these patients are in an existential crisis, and not everyone's always done fertility preservation or had these conversations about fertility preservation. And I think if you come from a place of, not assuming anything and just really trying to be there to be helpful, I think across the board, all the providers are going to appreciate that you're not there blaming them that they've not done fertility preservation in the past. And I think that can create a little bit of a defensive, feel from some of these oncologists. I also am a big fan of asking for help. And I think as a navigator, if your specialty has been in oncology and you don't know reproductive medicine, then you should be shadowing your reproductive urologist, and you should be shadowing your reproductive endocrinologist. You should be in the clinic with them so you can hear how they're counseling their patients, how they're counseling your patients, so that you are speaking the same language to the patients and not causing confusion. So I think just being nice and always being open and wanting to learn, I think, are two sort of basic tenets of being a navigator.
You mentioned the efforts for, fertility preservation coverage and the signing of that bill here at Prentice by then Governor Rauner. And, you really sort of underplayed your role and personal involvement in that whole process. So I was just giving a lecture earlier today to a group, and they're asking me about, well, how did this happen? How do we advocate for our patients? How do we get laws to change? And, I explained that you're going to be speaking with this group in a few weeks down the road. But for this group here now, for our Advancements in Andrology group, how did that happen? And, at an individual level, what was your approach?
Yeah, I think the most that I knew about how a bill becomes a law was from Schoolhouse Rocks. And this was a big learning curve for me. Every state is very different with how they approach bill creation, and that's also been a learning curve for me. But here in Illinois, we had an amazing OB-GYN resident, Jessie Walter, who for a summer project wrote this bill. This was her summer project. She got it in the hands of a senator who was interested in pushing this forward. It went nowhere in the first year. So we were one of those yellow states that the bill went in and then it just died. And it wasn't until we got some of the medical societies involved, we got some lobbyists on board, and we started to have some real meetings about what should this bill look like, what do we need to do. And honestly, the Alliance for Fertility Preservation was huge in helping guide us with next steps. So we formed this kind of coalition, and myself, Jesse Walter, who was then in fellowship at Penn, and one of my patients drove down to Springfield, and we testified in front of all these lawmakers. And what I will say is that I was really shocked that most of these lawmakers have zero medical background. So I was explaining reproductive biology to them like I would to a 12-year-old, because some of them really have no idea. And so we took it down to reproductive biology, how cancer treatments impact that, and then just got peppered with questions from these lawmakers, who some of them were saying we don't like a mandate type of situation. So after a few of those types of sessions, we really got a lot of patient involvement, where we were having patients send letters to their lawmakers so that their respective lawmakers could see how important this was to their constituents. It finally made its way to the governor. And then within the governor, we had to then sit and talk dollars, right? Because they all want to know, is this going to cost the state money? So we had to have all those conversations. And honestly, it involved about a year of my life where I was on call to either drive down to Springfield at the drop of a hat or be in a meeting in downtown Chicago at the drop of a hat. But it's worth it because it has made our patients' lives so much better when they can pursue fertility preservation. And I think selfishly, too, from my standpoint, when I'm on a call with a patient and I'm talking to them about all these different treatments, one of the things they always say is, well, this is going to be really expensive, isn't it? And it's such a beautiful thing to say to them, well, it isn't, because your insurance, as it should, is going to pay for this. And so I will do that again and again and again. In fact, a law was just introduced in Indiana, which is my home state. Even though I don't live there anymore, I just sent the representative there some information so that I can get involved in getting that bill passed. Because I think for our patients, these laws make a huge difference in their lives. And we do so much to help them on the medical side, but we can also do so much on the legislative side. So I would say if anyone's interested, I'm more than happy to have more conversations, help you get involved. We always need more support when we're doing these bills and talking with lawmakers.
Excellent. Certainly want to open up the floor to questions from any of the attendees. If any of you have any questions for Kristin.
I want to just publicly thank Kristin for all of her contributions to this field. I have had the pleasure of seeing it firsthand as far as your kind of clinical care and how amazing it is to be part of an organization that has somebody who's so passionate about fertility preservation. And really, as you mentioned, at the drop of a hat, always being ready, whether it's the evening, the weekend, et cetera, to take care of patients. And that kind of passion is really what it takes to take care of these patients, because we always used to joke that, the toughest cases are always going to show up at the hardest times, right? It's always, Christmas Eve, the lab is closed, and that's when you really get to understand who is really committed to this. But the other thing is, I think and Dr. Brannigan alluded to this, you've talked about this a little bit, your career and your professional advancements and, how much you've really steered our field has been pretty amazing. That does lead me to a question, which is, one of the things that we're seeing more and more is research that is, as you mentioned, getting from the bench to the bedside in fertility preservation in these adolescent and young adults. And even this week, we saw some really exciting, work coming out of Dr. Orwig's group about this really making its way to the bedside. And so I'm wondering how you, as a navigator, you've always been at the epicenter of this, but how do you see your role in research? How do you see kind of how navigators are going to be involved in bringing some of these things, which I think even a few years ago seemed like it was going to be in the distant future, to now bringing this to the bedside?
Yeah, thank you, Josh, for all the lovely, kind words. And, I think as navigators, I think it's imperative that what's going on around the country. And so in particular, mentioning Dr. Kyle Orwig, he has an amazing testicular tissue cryopreservation study. He's doing, the vast majority of the research that's happening in that field. And what I will tell you is that as someone who, I answer the National Oncofertility Hotline. And for a lot of his initial first patients, these were patients who were calling me in Chicago asking about it, and I was sending them to Kyle. And I think it's by having that sort of interconnectedness with these basic scientists who are really the movers and shakers of this field, who are going to push these options forward for our patients so that they have opportunities at biological parenthood. I think when you're connected to them, then you're able to talk to patients about, the basics of it. I'm not giving all the details. I'm going to leave that to Kyle and his team. But then I know how these patients can get involved. And so I think knowing all these different pathways around the country is imperative for navigators so that they can ensure that their patients get access to all the best care that we have in the United States to offer.
Thanks, Josh and Kristin. Appreciate that. Any other questions from the group? I should point out Dr. Halpern is a former faculty member here who bent over backwards to provide outstanding fertility preservation care for all the years he was here, and definitely helped a lot of these couples, move their dreams forward in terms of having children in the setting of cancer or other diagnoses that affect fertility. So thanks for all your work over the years, Josh. Really, really appreciate it. So I guess, yeah, we do miss Dr. Halpern. So I think with that, we're at the close of our hour. So Kristin, thank you so much for taking the time. And, the vast majority of views of these sessions are asynchronous. So down the road, I would just encourage you to the viewer, Kristin has posted her contact information. And if you find yourself down the road looking at this and wondering if you should or shouldn't contact Kristin, please do feel free to reach out. She is incredibly accessible and kind and will help you and your patient move forward through their care. And if you have a professional question or issue you want to address with her, again, feel free, because how do I know? Because I myself have done it innumerable times. So with that, we will close this session and thank everyone for their participation and look forward to seeing you next time. Thank you.
Thank you so much.